So you're obviously not a student, or not a. You're always a student.
Always.
So you guys are student. What year?
We're all fourth years.
Fourth year.
They've all matched.
Yes.
Oh, you have.
Yes.
Okay.
Yeah.
So what are we going to be doing next year?
Family medicine at U at PMC, Susquehanna in Williamsport, Pennsylvania.
Family medicine as well.
Family medicine in Colorado.
And a medicine here at Campbell School.
Yeah, because this stuff, I don't know how an MD practices family medicine without knowing OMT. I just don't know either, because there's so many conditions that you see that the only answer is an osteopathic approach. And I think, it just would be totally frustrating without knowing it. So let me give you a little back on where I'm coming from, because I never thought I'd be a physician. I thought you had to be smart to be a doctor. And I went to a small liberal arts college up in Maine and got a degree in organic chemistry. And didn't know what I wanted to do. I knew I didn't want to do graduate work in organic. And I didn't know what I wanted to do. So I took a job for Pfizer Laboratories and carrying a bag, what they called in those days detailing doctors, talking to them about new drugs and giving them samples and bribing them with samples and stuff. And this was up in Maine. And so I had a lot of DOs in my territory. I had 4 DO hospitals in my territory. And I grew up in Connecticut. And when growing up in Connecticut, DOs had a limited license. They could do OMT, they couldn't write a script for aspirin. And so a DO had helped me. I was a competitive swimmer. My senior year, it hurt my back and I was getting nowhere. To show how things changed, how they treated you with low back pain, that is, gave you a brace, and then there were no muscle relaxants. The only anti-inflammatory, and they really didn't think of it as an anti-inflammatory, was aspirin. And so they gave me phenobarb too, because there were no muscle relaxants. And I wasn't getting anywhere, so my parents took me to this DO. He treated me a couple of times, and I'm back swimming. So I thought he was a chiropractor or something. And so then all of a sudden I got a bunch of DOs in my territory and DO hospitals. And I thought, this is fascinating. So when you're calling on docs, you spend a lot of time in their waiting rooms. And I spent a lot of time in MD's offices hearing people complain about musculoskeletal stuff and not getting better. And then I spent time in DO's offices hearing the same story, saying how OMT had helped him tremendously. And so then when I started calling on the doctors, I thought, man, if these birds did it, I can do it. I'm going back. So a year after I started with Pfizer, I went to Kirksville. And our first day of class, the California merger was taking place. And they were coming into class in Kirksville saying, we don't know whether you're going to graduate as MDs or DOs. We don't know if there's going to be an osteopathic profession when you graduate. You know, I'm sitting there thinking, I wonder if I made the right career choice. But then I thought, well, I think I want to be a primary care doctor. And if I am, I know I want to use manipulation. And a lot of my classmates immediately transferred out to MD schools. But I thought, no, I'm staying because I want to learn the manipulation. And if I end up with an MD, I'll at least still have the manipulation. So I'm staying. But then the first 6 months of OMT classes, it was all palpation, and I could not feel what they were talking about. And I thought, man, I don't know if I made the right decision. And there were 4 other people in my class who had relatives that were DOs that did a lot of manipulation. And they wanted to learn it. We were all frustrated with the way it was being taught. So we started a small study group. You know, we went to various faculty members at Kirksville and said, we understand you do OMT and you're an internist or a surgeon or whatever. Would you come and spend an evening with us and tell us what you do? And show us what you do. And they said, sure. So they came and did it. One night, one of them said, boy, you're really interested in this stuff. You need to know George Laughlin. I said, who's he? We've never heard about him. They said, well, he's a real loner. He practices across the street at Laughlin Hospital. He doesn't have anything to do with the school, but he's one of the best manipulators in the area. And if you want, I'll introduce you to him. And he was Still's grandson. His mother was Blanche Still, so Still's youngest daughter. And then she married Laughlin. And so this was George Laughlin I was working with, was the grandson. And what was so neat, George's grandson, so it would have been Still's great-great-grandson was my plus resident in Pikeville 2 years ago, which was
Oh, wow.
was really neat. And the family said, go to Pikeville and learn what your grandfather was doing. So it was really neat to teach him. But what George did, that I told him, I said, I'm having trouble with palpation. And I wonder if I made a mistake. And he said to one of my classmates, get up here on the table. And he did a little screen, and he said, okay, there's a lesion right here. He said, you get your thumbs right here. Now get your thumbs close to the spinous process, but just lateral to the medial to the transverse. I want you right over the facets. And when you bend forward, the facet should open. When you extend back, the facet should close. If they bend forward and your right thumb rides up and your left one doesn't, it means that left pair won't open up. If they extend back and your thumb comes down and back, it means that side's closing, this side isn't closing. And as soon as all I had to decide was something opening or closing, I could feel that. Okay. And then after a short time, I said, is this an acute one? Is this a chronic one? Palpatory skills came like everything. So I learned from that I think you can teach palpation real fast if you teach the mechanics and then say, okay, here's where you want to palpate, and here's a couple of options. And students can pick up on that real fast. So that changed my career. And then he did all indirect techniques. And in the first night, he said to us, I'll be glad to show you what I do and tell you what I do, but if you're here to argue and debate, I'm out of here. So we didn't want to spook the guy, you know? And he couldn't explain, see, what you don't realize in 1961, the only techniques available to the osteopathic profession were articular techniques, soft tissue techniques, and high velocity. Everything else you're learning was not available. Okay? Nobody was talking about barriers. Nobody was talking about going direct and indirect. Okay? And all George could say to me was, take the doodad where it wants to go and fiddle and diddle. So what do you mean? You said, well, you'll eventually get to know. So what the basic line of functional is take them where they want to go, the positional diagnosis, and fiddle and diddle to fine-tune the facet or the sacroiliac joint or whatever you're treating, and you're going to get good results. Okay? So he really gave me a perfect explanation. The problem was he didn't give me the translation. Okay? But that changed, so I started playing with functional and started getting some good results, but they weren't dependable results. Then I graduated in '65. Boy, it was a blessing this morning because I saw on the program that Isaiah Halleck, we were classmates. And I hadn't seen him since we graduated, so we got a chance to talk for quite a while this morning. And really neat to see, boy, he made a change in this area, didn't he? Whoa, man. And, oh, where is it now? I lost my track.
I graduated Kirksville.
65, yeah. So then in '70, I learned muscle energy. I was in the first muscle energy tutorial group where Mitchell handpicked 6 people. And he, because he was lecturing on muscle energy and nobody was getting it because there was no hands-on practice time. Okay? So Sally Sutton, who practiced in Fort Dodge, Iowa, went to him and said, Fred, I've got a home office combination. She had a building that was 2 layers. Her home was upstairs, the office downstairs. And she said, you need to come, I'll sponsor the course, do a 5-day course. You handpick 6 people. And if 6 people learn this stuff, then I think they can start spreading it. And my roommate that week was somebody I'd never met, Phil Greenman. So then that tied us together. And then what I realized later, that whole muscle energy diagnostic system that Mitchell came up with, if I just said, go away from the barrier and position them at their positional diagnosis and fill into the find, then you can explain function. So then I was able to teach function, like everything. And what I've realized over the last couple of years, muscle energy is being taught, a lot of schools is totally different than it was originally taught. And Mitchell was a mechanical engineer, but he was a great teacher. And he didn't just teach you something, he gave you the reason why you should know that. And then he always taught how to apply it, and how to adapt it to the patient, rather than adapting the patient to the problem. And so about 3 or 4 years ago, I started thinking, whenever I teach muscle energy now, I'm gonna go back and teach it more the way Mitchell did. And show you where, because they're mimicking techniques and they don't know the thought process that went behind the whole thing. So we'll be doing some of that. Okay? And so then after that, Mitchell or Greenman and I, we always treated each other when we were ever together. Every once in a while, I do a functional technique on him, and he'd say, "Man, that's great. What's that?" "Oh, it's a Laughlin technique." So you got to teach a course, a 3-day course in that at Michigan State. And I always to humor him. I'd say, "Oh yeah." And inside, I'm thinking, "Yeah, I'm going to spend 3 days, say, take the due date where it wants to go." And so you're crazy as hell. There's no way I'm going to teach that course. So in the fall of '89, Greenman said to me, "Oh, by the way," because we just went through that dance again. He said, "By the way, in spring of '89, you're teaching a functional course at Michigan State. We've invited people from all over the world, and you got a year and a half to put the course together." And what I realized was, with the muscle energy diagnostic system, I could easily teach functional for the whole body. And then I went back to Kirksville because I wanted to talk to his widow, because George was a residency-trained surgeon. His father was a surgeon, his uncle was a surgeon, his cousin was a surgeon, he was a surgeon, but he had a spondylolisthesis at L5S1, so standing at the operating table killed his back. So he quit doing surgery and did strictly an OMT practice, but it was all high velocity. So, and I never, because I didn't want to spook the guy, I didn't want to ask him too many questions, and I just assumed somebody had taught him this, but I don't know, I should have asked him more. But anyway, I went back, and his wife's maiden name was Peterson, her nickname was Pete. And we had developed a good relationship over the 20 years that he mentored me. And I went back and I said, "Pete, let me ask you a question. I know George did surgery, then he did a high velocity practice. When did he start doing that Ouija board, voodoo type manipulation?" And he had been dead 8 or 9 years, so I figured she's going to have to stop and think about it. She didn't pause a nanosecond. And she said he started doing that, it never changed from the moment he came back from the first Sutherland cranial course. And that was a 2-week course. And I think what happened was, during the 2 weeks, Sutherland took George aside and said, "George, let me show you what your grandfather was," and taught him all the indirect stuff. And he came practice that way. And I'm also suspicious that what Sutherland said to him, George, is, now that you've got these principles, they also apply to the sutures, but he didn't say that to the rest of the cranium. So George taught me as a student how to approach the cranium from a sutural approach, which can really be neat and really be fun. So we may get a chance to talk a little bit about that too. So I never thought I'd be in education, and then 20 years ago they approached me about coming to Pikeville. And Pikeville, Kentucky is an amazing, amazing area. It's a town of 7,000 people. And in the 80s, there were more millionaires per square mile in Pikeville, Kentucky than any city in the United States. And the reason is there's more coal under Pike County than the whole state of West Virginia. There's more natural gas under Pike County than the rest of the state of Kentucky. So it's energy rich. And so there are a lot of millionaires. In a town of 7,000, they want good health care. They don't want to have to go to Lexington, Louisville, Nashville, Charleston, Huntington. So we have a 400-bed hospital with all the specialties and subspecialties. We have a flexion extension MRI. I mean, it's unbelievable. And it's really an anomaly. And so then why they approached me, it was all MDs. There was one DO in that whole region. And so then they're going to start an osteopathic school. And the environment we went into when it was announced there was going to be an osteopathic school, the dean of the medical school, Emory Wilson, was quoted as saying, "The only thing that would be worse than having an osteopathic school in Pikeville, Kentucky, would be to have a third law school." And this was the environment we went into. Okay. And so Mike Megan was the original dean at Michigan State. He was appointed as the AOA to be their consultant to help them shepherd through the accrediting process. And Mike called me and said, "Hey, you've been doing teaching for me in the postgraduate stuff with MDs and dentists and stuff with PTs. They're all MDs down there." And he said, "Nobody thinks this is going to go," but he said, "I've got a gut feeling this thing is going to go." Because one of the people behind it had just been elected governor. Yeah. And then several of the gazillionaires in Pikeville got behind it. And so we got the school going. And so now about 25% of the staff at Pikeville Medical Center are DOs, and most of them are our graduates. And there's data out there now saying, because that was a very underserved area for physicians, that 1.6 million people are in that area are now getting health care from Pikeville graduates. So we've really changed the region. So it's been a lot of fun, and a lot of OMTs been done in the area. So it's been fun, been a fun career. So you wanted to do the pelvis.
The last one, pelvis, but it's up to you.
Well, let's do the pelvis, and then let me give you the background on it, and then see, because this is the slides I'm going to use this afternoon. So let me change some things around here. This one. Used to this computer PC.
Just kidding.
How do I get it out of here? Does anybody know how to get this warning thing out of here?
I don't know Windows.
I don't know either. It's like a foreign language to me.
Yeah.
Let's see. Let's see.
How was it? I thought you
It's great. That was, I came back just because.
Now remember to teach Dallin.
I will have to.
Because Dallin is missing.
Yeah. He sent me this,
Okay.
I think he's doing the wilderness medicine.
Yeah.
Yeah.
He's up in
He was
Utah.
like,
You should be back tomorrow.
Yeah, they're like,
He's like, are you
breastfeeding.
doing Hawaii? Because I'm doing this.
It's like, oh, okay.
And we'd rather be in Hawaii.
Cliff rescuing and stuff.
It's good. I'm glad you showed up. I'm glad you're
Dallin,
I'm glad you're like going.
he's one of our classmates. He's doing a wilderness medicine.
Okay.
Want me to switch spots with you? Or should we get it?
No. No, I can click it from here now.
Okay, there we go.
In wilderness.
Yeah.
Finding.
So one of the things I want to show you is how things have changed during my years of practice. So some 50, 40 years or some kind of thing of practice. And so the traditional musculoskeletal pictures, but do they talk to you much in school about tensegrity? But this was produced by a guy named Snelson up Northwest. And you can see it's a tensegrity model of the pelvis. And obviously there are no motors or muscles attached to that. But if you put that on an incline, it walks down the incline in cross pattern walking. Talk about structure determining function. You know? So what I want to do is talk about, then let me give you a quick update, because this will apply a lot of what we're going to be doing with the pelvis. Okay? So tensegrity, this is on the mall in Washington, and you can see it's a sculpture with a bunch of straight rods that do not touch, but they're all interconnected by wires. Okay? And Ingber at Harvard is saying the 206 bones of the body represent those rods. The wires represent the myofascial tissues of the body, and that the musculoskeletal system is really designed as a tensegrity system. So what are the characteristics of that design then? Those systems are very lightweight. They're much stronger than anybody would ever predict from a biomechanical standpoint. They move in all sorts of directions. The whole system adapts to a stressor. And I've walked up to that thing and hit one of the rods, and the whole system adapts. And if you hit one of the wires, the whole system adapts. It's amazing. Tensegrity systems protect the weakest link in that system. See, and to me, that's why we want to find the area of greatest restriction. To me, that's the weakest link in the system. And so that whole system then is adapting and trying to protect it. And I think when we find it, And then when we treat it, does the whole system say, whoa, he found the area, now let's all adapt and let's help that start to function better. And I think that's why you have such a profound effect on the whole body when you treat the key area. It defies gravity. Now most students, when you say that, their eyes roll back and say, what are you talking about? And their big rods go down to the ground, and all around that there's signs, do not touch. I've been there because when I banged it, you know, I'm looking. So another time I've been there and looking around, I walked over and put my hands on one of the bars that went down to the ground and took my feet off the ground. And the whole thing started to minutely shake. Then it stopped, and then it lifted me right up. So what it did is it changed the pre-stress in the system. The whole system adapted. And then I never could explain why lots of times after I treated patients, they'd say, I feel weird. You don't like to hear that. I say, what do you mean you feel weird? I feel taller and I feel lighter. Never could explain it. There's the explanation. What you've done is you've activated the tensegrity phenomenon in that patient. Non-metallic materials organized into a tensegrity array will conduct electricity. How many times when you're treating somebody, you feel like a rush of energy goes through? And you can get some weird explanations of that. But tensegrity says, oh, that shouldn't be uncommon. Okay? We're wired to keep our eyes level and our weight evenly distributed. And in the traditional musculoskeletal model, it's hard to do that. But with tensegrity, man, you can adapt like everything to any area of dysfunction in the whole body. So that's why I think that's how our system is designed. They also conduct vibratory information, which is another messaging system. So could somatic dysfunction impact energy going through the system and vibratory? Are we changing signaling system in the body that normal neurophysiologists aren't even talking about? But if we take the somatic dysfunction out, could we be helping to restore that? See, we had a philosopher at Pikeville that was an amazing guy. It's so ironic that I'm telling this story. He grew up in Tucson. And his father was an MD, his grandfather was an MD, and two uncles that were MDs. And one day they were driving by, he said he was about 10 years old. They were driving by the old Tucson Osteopathic Hospital. And he said to his father, what's that? And his father said, that's where the quacks practice. So that was his exposure to osteopathy. So then he graduates from the University of Arizona, goes to Princeton to do his graduate work and get his PhD, and got into all sorts of stuff. That was he understood this, the philosophy of science, the history of science. He understood Kuhn paradigm stuff. He understood linguistics, and he read all of Stiles' stuff. And it's interesting because what he taught me was historians can read what people say and come to a totally different conclusion than a linguistic person reading that same stuff. And what he said to me was, what Stiles was saying was, examine your patient and find the hindrances to a healthy physiology. Remove the hindrances. That was the find it, fix it. Leave it alone. Okay? So are we changing all sorts of stuff? Now, in Europe now, they're starting to talk about curved tensegrity. And curved tensegrity is the rods are curved, and what's neat is those systems, when you stress them, they expand. Okay? Is that what's going on in the pelvis, the cranium, the rib cage, and I think those are the hands and feet. Because how many times you treat a pelvis or a rib, it just seems like it expands. Well, curved tensegrity will do that. Now, think about it the other way. This first tensegrity, the straight line, let's see, where's mine? Okay, here we go. The straight rods, those systems, when you stress them, they pull in to get stronger. So wouldn't that be appropriate for legs to support our trunk? And our arms, when we're lifting something heavy, that could bear a lot more weight because tensegrity is pulling it in to make it stronger. Whereas when you stress the curved tensegrity, it tends to expand. And when I read that, I thought, God, I can't believe I got sucked into the thought that the baby's head was expanding because the brain was expanding. But what do we know about the nervous system? It doesn't like pressure on it. But curved tensegrity, if the bones are enlarging, and that's enlarging, could that then make us vacuum like a space in a way for that brain to enlarge without any pressure on it? So I think that's the the way I look at the musculoskeletal system now is it's how it functions. Look at the Statue of Liberty. It's a tensegrity system. And the arm up in the air with the torch, they say that arm can move 18 inches in any direction depending on which way the wind is blowing. See, that looks like a solid monument, but it isn't. It's a tensegrity system. And about 20 years ago, a big national thing went on to get money to restore it because they realized it was tensegrity, and the whole thing could come crashing down. But isn't that a hoot? Now, in Europe, they're saying we need to change the name of the musculoskeletal system. That we need to call it the mesokinetic system. Because, when we go through this, I think you'll agree that we really should do that. So, now when I looked at this up, I probably had embryology 45 years ago, so I don't know how much you remember of your embryology.
I remember it 2 years ago.
So I got out Netter's Human Embryology book, and look at the structures that are derived from mesoderm. Connective tissue and fascia, cartilage, bone, smooth and striated muscle. Myocardium, pericardium, blood vessels and lymph vessels. Kidneys, ureters, adrenal cortex. The gonads, the tubes, the uterus, and the upper vagina. The serous lining of the thoracic area, abdominal area, and pelvis area, all derived from mesoderm. The GI fascial support system, all mesoderm. The spleen. Now, think about that. If all those tissues, well, let me go back a step. When I started the first hospital-based program in Waterville, Maine in '73. And we were the first hospital in the country to have somebody working full-time in the hospital doing OMT. And what I found was when I treated people and got their specific dysfunctions out, we got unbelievable data. And really, the changes in length of stay, immediate changes in pulmonary function tests, things like this. It was unbelievable. And I always came to the conclusion out of that, if you got the musculoskeletal system functioning properly, that I thought a lot of times the visceral stuff kind of took care of itself because visceral technique was just beginning to come on the scene. Okay? So nobody was really talking about it a lot. And, but think about it, if they're all mesodermal and you get the musculoskeletal system working right, are we having a profound effect on all that visceral also without ever doing a visceral technique? And I think we may be, okay? But did you remember all those structures? And then kinetic would be movement. So isn't that more descriptive term of the system? It's mesodermal derived and it has to do with motion. It's a lot better term than musculoskeletal. So I think the Europeans may have it right. Now, Alan Becker was interviewed a few months before he died. And look at this quote. Still was very keen on being very specific. He looked at the patient as a totality. He looked for that elusive key lesion, or Tony Chila hates the word, that area of greatest restriction. He likes hindrance. So, in deference to Chila, I started adding hindrance to all these things. The somatic dysfunction that people have quoted for years. That's what he looked for. And when he found it, he fixed it and he left it alone. He said that once done, the body will do its own work because it's designed to do its own work. Our job is to find the key restriction or hindrance to homeostatic integrity, and once restored to normalcy, to rest assured the body will take care of itself. And I'm so amazed at how true that is. And we had one of our grads was back in Pikeville last week. He's an orthopedic surgeon down in Tampa. That does a lot. We've done some OMT with golfers, and we put them do all sorts of testing with them. Then I take them off in sequence and treat them, put them back on the testing stuff, and show unbelievable change in the performance of the golfers. Unbelievable. And but he was telling me a story that blew me away. There's research out there now showing that if you tear an ACL, and if they do it in an animal, and get the fluid out of the knee and put a hematoma there, it will heal and doesn't require surgery. Wow. That says to me, we're dealing with an unbelievable self-healing potential system. So I went back and looked at 100 patients with low back pain. I went to my receptionist and said, pull the appointment book 5 years ago. And when they made the appointment with the patient, they put in what their chief complaint was. So I said, I want you to pull the first 100 low back patients, with or without sciatica. And then I went through them. And when those are all handwritten records. So when I recorded my record, if I put T5 ERS left and left it that way, I know I used muscle energy. If I put a T after it, I know I used a thrusting technique. If I put an F after it, I knew I used functional technique. See, so I could look at that and I knew the sequence I treated the patient, and then I got the recall on the type of technique. And this was Kimberly that taught me this one. He said, whenever you find dysfunction, how are you going to decide on what technique you use? And he said, if it's really acute, always use an indirect technique. If it's if you got dysfunction and there's some localized swelling, use muscle energy, because as they contract and relax the muscles, they pump the edema out of the tissues. If it's more muscular, then use muscle energy, because you're using the muscles to reestablish normal mechanics, and then the dysfunction can correct. Plus, you're teaching them to use the muscles they need to maintain that correction. Then if it's fused, or if it's chronic, and if it has a leathery feel, that's when high velocity is really superb. And if it's been fused either naturally or surgically, then I'm going to use functional on everything above and below that, trying to help them compensate so they don't develop a second disc and require a second laminectomy. Okay? So when I do my screen, I know where I'm going to start, and I know the technique I'm going to use to treat that. Okay? And then every dysfunction I find, I'm going to match the technique to the barrier. And when you do, I think your results. Whereas a lot of people say, well, Stiles just muscle energy, or I'm just functional. They didn't watch me practice. So I went back, and it blew me away, because when I looked at those 100 patients, I did not understand my practice. And what I found was the area of greatest restriction at 60% was thoracic area rib cage. That the first area that needed to be treated. Now, think about it. If that rib cage isn't working right, think what that could do to the abdominals and quadratus. Think what that could do to pelvic mechanics. Okay? The second area of greatest restriction was lumbar, 24%. So that was the first area that I treated 24% of the time. Lower extremity was where I started in those low back patients, 11% of the time. Now look at, that represents 95%. And do you notice something? The sacrum and the innominate were not the initial area of greatest restriction. And what do most students do get low back pain? They go right for the sacrum and the pelvis, and you can be getting into all sorts of adaptations that just drive you crazy. Okay?
Can I ask you?
Yeah.
So you said this was the key somatic dysfunction. How did you identify? Was this the greatest restricted area?
My screening exam.
Okay, gotcha.
Yep. Now, look at, also, cranium through the dural tube can affect sacral mechanics like everything. Think about it. Dysfunction in the upper extremities can affect the lats, can affect low back mechanics like everything. So then lower extremity, the same thing. But have you ever seen a research project designed where they looked at cranium, upper extremity, lower extremity, thoracic area, rib cage? That's why I think the outcomes for OMT with low back pain are good. They got the wrong model. Okay. And Mitchell, the first course he taught us, he said, I can write a prescription for you to fail doing OMT. And here's the prescription, chase pain. See, and that's why I say to be good DOs, especially when you're going into like family practice, you've really clinically got to be a clinically schizophrenic. From the allopathic side, learn to work it as well as any MD. But I think that then you got to look at what I'd say the host side, and that's totally different. And in the allopathic side, basically, you're chasing pain. You need to be doing that. But if you carry that over into the osteopathic, it's going to get you into trouble. Now, here's how I look at patients now. Now, anybody know what this is? You gotta be from Appalachia. That's a Gordian knot. And how you make a Gordian knot, you take a long piece of like rope and splice the ends together. Then you make a knot, then you make a knot backwards, and then you make a knot this way, make a knot that way, and then that's what you get as a Gordian knot. So when I walk into the room with a new patient, that's the mental image I got. And Core in Kirksville, he helped me tremendously clinically, because he had a great saying. He said, you can have 100 patients that have exactly the same medical diagnosis, but what you have to remember is they all got there by a different route. That's why each patient is unique, and each patient is one of a kind. So that's why I want to treat them uniquely as possible, because they're very complex. I don't want to just blast into that system. Okay? So I look at the patient as they're complex, dynamic, interconnected, and interwoven systems, multiple simultaneously functioning systems that are going on. It's a nonlinear system. It's autopoietic. You know, are you familiar with that word? Because Robert Davis got me into this. It's dynamic, structure, and function. It's what's one of Stiles' basic premise. Structure and function are related. So to me, when I say that, that just kind of sits there. What autopoiesis says, oh, it's dynamic and constantly changing. See, that to me is alive. And when I first really saw the example of that, I had a bunch of orthopods in a postgraduate course at Michigan State. And we examined this patient, or I examined the patient, and I said, look, the left crest is higher than the right crest. The right anterior superior spine is higher than no, I'm saying lower. So the right side was low, crest was lower. Right anterior superior spine was lower than the left. The right pubes was more cephalad than the left. And I had them all examine it. They said, we totally agree. They said, what do you think's going on? I said, I've never seen that. I said, the only way I know how to explain it is it's probably a small hemipelvis. Because if the pubes and the anterior superior spine are closer together, that suggests that anomaly is smaller than the one on the other side. Screened the patient out, treated him, got through, we rechecked it, everything was normal, level. And some of the orthopods said, since we've learned the osteopathic stuff, we're convinced that because the sacrum has 3 transverse axes, 2 oblique axes, they're all simultaneously functioning, that when there's dysfunction, the anomalous literally can change shape. That's autopoiesis. That's dynamic structure and function, adaptation. But yet it's a functional unit. So I'm going to walk into that patient with unbelievable respect and try to find out where their key area is, and then go to the next one, and then go to the next one, and weave my way through the maze. And as I do, what I hope is that we unwind that Gordian knot and see. Think about other areas can feed into that low back pain. Organ systems can feed into that low back pain. So that is a complex patient when they walk in with, say, low back pain. This would be a good, because this changed my, well, let me do it this way. Mitchell changed the first day of that tutorial, changed my paradigms, shook them, turned them upside down on me. And the first morning, he was demonstrating muscle energy stuff, and I raised my hand. I said, Dr. Mitchell, I'm having trouble. I said, Kirksville, I was trained all high velocity, and I'm having trouble believing that a little bit of a muscle energy effort can make the changes you say it can make, and some of the changes we've already seen. And he was neat. He would say, well, you just don't know what the hell you're talking about, or, you don't have the experience, and, he just always had a way of demonstrating. So he got up and he took a rolling stool and put it in the center of the room. He walked up and kicked it hard, and the stool moved about 3 feet. He said, that's like a high velocity, low amplitude technique. He brought it back, put his pinky on it, and pushed it across the room, and he said, you forgot the definition of work. It's force times time. So a little bit of muscle energy effort over several seconds can actually produce far more work than a lot of force for a nanosecond. That was a paradigm shift. So, woo. Then the other one, he said, in the morning, I said, because Kirksville, the sign of you or DO, you did rib raising and lymphatic pump. I said, did you do a lymphatic pump? He said, nope. I said, really? Nope. He said, don't you think it works? I know it works. I said, what? Then why couldn't I think you're a hypocrite? You know something works, but you don't use it with your patients. Why? And he said, here's why. When I do the lymphatic pump, I know it's going to circulate fluid. But as soon as I stop, the process stops. And what the Texas literature shows, what? 45 seconds, the pumping effect. He said, but if I screen my patient out and get them functional, every time they take a breath, they give themselves the lymphatic pump. And I thought, I want to think like that. That makes sense. And then the first cardiac patient I saw in Waterville, because when I went in there, the internists had come out of Kirksville, and for them, manipulation was high velocity. They were saying, you're not going to be treating my cardiac patients. And I said, I can do it gently and functionally, because going through Kirksville, they never met lawful. Okay. So one day, one of the internists comes up to me and says, hey, I'm desperate. I said, what's the matter? He said, I got a patient up in the unit that's in terminal congestive failure. We've done everything known to man, and he's just going downhill. Come on up with me and show me how you can treat him gently. So I could. I'm thinking, boy, okay. So we go up. The guy's got ankle edema like this. You could palpate the liver down the lower right quadrant. It was so congested. Lungs are moisture or anything, and I'm thinking, what in the hell have I got myself in? So I did a modified screen, because I do a screen in the intensive care unit. So I could screen cranium, screen the cervical area, do a modified rib raising, and then it'll go all the way down to the sacroiliacs. And if it's mostly thoracic, then that's where I'm going to start. If it's mostly lumbar, that's where I'm going to start. And I did both sides, and I thought, man, most of this is in the upper thoracic area. About T3, T4, that could be cardiac, sympathetic vasomotor supply to the heart. So all I had to do was slide my hand under there, get his head and say, does it want to flex or extend? It wants to flex. Does it want to side bend left or right? Right. Does it want to rotate left or right? Right. FRS right. Put a little compression in, thing released. That's pretty good. So then I rechecked the thoracic area. Now there's an area down about T5. And when I sprung laterally along the ribs, it got worse. That says to me the rib cage is the area grade. So I screened him, found the key rib, got on the back end, the front end of the key rib, took it where I wanted to go, took it, put a little belt, that thing released. So then I rescreened, now it's cervical. Thought, this could be the vagal input into this. And you're always taught vagal is upper cervical. I don't buy it. Because if you look at a cross-section of the cervical area, all the fascial sheets from every group of muscles attached to the carotid sheath. And what's going down through the carotid canal? The vagus. So I think cervical dysfunction anywhere in there can affect that vagus. Okay, so I don't, tell them on board, yep, upper cervical. Okay. And treated the cervical thing. Didn't find anything else I thought I needed to treat. Dictated the report, and I'm thinking, I think that was probably the biggest waste of time. Man alive. Well, I knew the internist made rounds early. So I was in the hospital early. Got there just about when he did. We go up. Ankle size was normal. Liver size was normal. Lungs were. He peed out 20 pounds of urine that night. And I thought, Mitchell had it right. Once I got him mechanically, where every breath he took, he was giving himself the lymphatic pump. Now, and see, the other thing I think happened was, because we treated the specific thoracic and cervical stuff, and I hate the term balance the autonomic nervous system. You tell me an activity when they're balanced. I wish we used the term appropriate sympathetic input, appropriate parasympathetic input. Okay? Because they're constantly fluctuating. See, and I think because we address those, then the heart could then handle that load of fluid. If we had just done a lymphatic pump and had done that, is there a possibility that we could have overloaded that heart? So that's why I think more and more, I want to find the hindrances and get them out of the way first. Then if that doesn't do the job, yeah, then I'll consider doing lymphatic pump and stuff. But I don't start right there. Okay? Makes sense? But there's a lot of paradigm shifts with Mitchell. Woo! Here was another one. He said, if you go to convocation, have you all been to convocation? Oh, got to go to convocation. He said, there are a lot of DOs that are good manipulators that don't have a clue in what they're doing. but they are good. But he said, if you understand this slide, you can figure out what they're doing. So the two things you need to know is, what's the diagnosis? And then once you've got the diagnosis, are they going directly or indirectly against the restrictive barrier? Okay. Then the other piece you need to know is, what is the corrective force? Is it a physician-introduced thrust, or as the Europeans say, an impulse? Or is it a muscle energy effort? Or are you tapping into the self-healing potential of the body? Okay. And if you do that, you can watch somebody, you can explain to them what they're doing, even though they don't understand what the hell they're doing. Okay? Isn't it a neat way to break down all technique? See, and where Mitchell really turned the academy upside down, because when he came in after that first tutorial, the academy was mostly high velocity. Then Mitchell comes in one day and says, I got a whole new diagnostic system for every joint in the body, and a new corrective force, and it's a patient muscle effort. People, it's not a physician thrust. They went crazy. But that's, see, and then a few years later, Larry Jones comes in and says, hey, I got a whole new diagnostic system, and the corrective force is properly positioning the patient to shut that mechanism down. That really screwed up a lot of people's minds in the academy, because everything was high velocity. They had to be fixing these people. This is Fred Mitchell Sr. And he was a mechanical engineer. Now we would say he was a creative thinker. He was a nonlinear thinker. He was thinking tensegrity before tensegrity was around as a mechanical engineer. I think if he walked in here now, he'd say, man, yeah, you didn't have the language, but nah, that's what I was doing in practice. He utilized cybernetics. What's cybernetics? You develop a feedback loop. So everything he did, he was asking myself, am I getting a positive response? Rather than just doing a technique. He was a complex adaptive systems thinker. Now, he was a phenomenologist, and I just frequently got familiar with this term in Europe. A phenomenologist is somebody that takes something, looks at it, looks at it, looks at it, and then all of a sudden they get an aha moment and they understand a little bit. Then they look at it, an aha moment, and what their goal is to understand what they call the authentic whole. See, it's the opposite of reductionist thinking that's trying to break everything down. And the reductionists can break everything down, but they never can put it back together again. Well, Still was a phenomenologist. Mitchell was a phenomenologist. He did this in the lab thinking, or he wasn't in the lab, he was leaning against a tree or thinking about his patients, thinking about it. He'd get an aha moment, then he understood it better and better and better and better. So he was a phenomenologist. And what's interesting is that approach it was started by Goethe, the famous poet. But he was quite a scientist too. But then it went out of vogue when reductionist science came in. It's back in vogue now because this phenomenology approach is helping to explain a lot of the things in quantum mechanics that they hadn't been able to understand. So that would explain why Mitchell then came up with that whole Mitchell model and a whole new way of explaining the mechanism that he was using, a direct technique, and the corrective force was a specific patient muscle effort. So people are teaching muscle energy as post-isometric relaxation. Mitchell would totally deny that. And you'll see why. We get those if you go this afternoon, because I'll make the case that it's not post-isometric relaxation. But what I want to do is this slide. You know, they say a picture's worth 1,000 words. Now look at it. He's treating something down, that looks like, that could be 8 or 9, right? But you know something? He's using the head. Now, how are thoracic ones taught now? Reaching around. Mitchell always used the head because he was sequencing people. And so if there was cervical stuff, he got that out before he treated the thoracic area. Whereas if people didn't recognize Mitchell was doing sequencing, and they tried to treat a thoracic one and they had cervical stuff, the patient complained, so people said, that's why I can't use the neck. That's when they started reaching around. Mitchell never did that, because he said, not only am I using the muscles to create motion, but I want to integrate the cervical, thoracic, and the lumbar. See, and that's why he was using translation. He wasn't just using flexion. He was using that translation, and he had that at the apex of the AP curve and the lateral curve. And if you do that, think about it, you're using the third law of spinal mechanics. You're restricting, in a limited way, a little way, everything above and below it. And if the vertebra you're treating is at the apex of the curve, man, you're making an offer it can't refuse. But that's what he was doing. See, and see, a lot of people, I see people doing muscle energy, they're reaching around, they get the patient way over here, and they're way here, they're way, Mitchell would stroke out. That's not it. This is Bob Ward, who was the editor of the first 2 volumes of Foundation. This is Phil Greenman. This is me in a previous life. But that, so many things, and look at, he's not working hard. He's got that patient translated so all the weight of the patient is over the pelvis and the patient is way off to the side. Fred isn't working hard. He's comfortable. Okay? And to do muscle, that's the way it should be with muscle energy. Now, in the first tutorial, he brought this stick and he put elastic bands on it because he was always stressing when you're treating the sacrum, find the vector for the muscle effort you put. Whereas a lot of people say, just push down, and I'll demonstrate this in a minute. Just push down. Now, and the sacrum won't move. You got to find the right vector. When you do, man, that thing just glides. Okay. See, and here's Shaitao, who's written a lot of books. And at the last fascia conference, he came out and said, muscle energy is not a post-isometric relaxation technique. Okay? So now, let me change slides to the... See if we can remember how to do this. Way here. The other thing is, if we get a chance, I'm doing some work with a PT up in Eugene, Oregon, and we're putting people on sophisticated treadmills, and you get their ground reactive force patterns, and we put them on and get a pre-OMT thing. Then I take them off, take them into the next room, sequence them out, treat them, put them back on, and we're seeing unbelievable changes in the ground reactive force immediately. And 80% of the time, first time I treat a patient, we're getting both statistically and fractally significant changes immediately. So we think we've got a new way of documenting somatic dysfunction changing performance. And one of the 3 of the patients I treated last time I was out there a year ago, March, I treated 3 elite runners, female runners. And they were really like 110 pounds, 120 pounds. But all 3 of them, the common denominator, when you put all their data together, the foot pressure was decreased between 8 to 10 pounds of pressure, which is amazing.
Wow.
Yeah. So we're getting some unique data. Now, I love this slide. Let me take you through a paradigm shift on the sacrum. Oh, good. Thank you. Now, to show you how things change, when I was a first-year student in Pikeville, or Kirksville, the Ville would come thank it. I mean, I was at Waterville, see, from Pikeville, I don't live in the town unless it has Ville at the end. But the model that I was taught was the sacrum was wedge-shaped, it was jammed in between the annominus to give stability. And in those days, if you said that you believed there was movement in the sacroiliac joint, not only were you a quack because you were a DO, you were a super quack. Okay? Because everybody knew there was no movement in the sacroiliac joints. Okay? And it was crazy. So then in Mitchell, in that first tutorial, he used this picture, which was a paradigm shift, and saying, look, the sacrum isn't jammed in between the innominate, it's suspended from the innominate by the posterior sacroiliac ligaments. So then if it's suspended and you got 3 transverse and 2 oblique axes, see, and I think there's also an AP axis. Then that sacrum, even though it's small movement, you can get unbelievable movements. And I've had people tell me, if you have a bone that has 6 axes, then the number of possible positions it can get in is a quantum number. Okay? So that means that sacrum is constantly adapting, trying to change. See, and if there wasn't any movement there, why do you have all these posterior ligaments? And then in the 90s, we started talking about tensegrity. And then in the 2013, started talking about curved tensegrity and how the pelvis is a curved tensegrity model. So, now what function on the superior transverse axis? Cranial sacral. Yep. How about the middle? That's sacrum flexion extension. How about the inferior transverse? That's the innominate. See, in the first morning in the tutorial, I used the term sacroiliac and iliosacral interchangeably. And Mitchell got red in the face and his neck vein stood out. And he pointed at me, he says, "You can't do that." I said, "What? I can't do what?" And he said, "You can't use the term sacroiliac and iliosacral interchangeable. Sacroiliac dysfunctions occur on the middle of the oblique axis. The iliosacral dysfunctions occur on the inferior transverse. They're totally different things. You can't use them interchangeably." Whoa. That makes sense. See, and then I think there's an AP axis. And then Mitchell always stressed that whenever 2 axes cross, that gives you even more motion potential. See, that's when you get into a quantum number of positions that sacrum can get in, if it's trying to adapt to stuff elsewhere in the body. Now, look at this tensegrity model. Look at these 2 rods do not touch and they're held apart. See? And I think the sacroiliac joint is a tensegrity system and it's being driven by those posterior ligaments that is enabling that to. And look at every picture I've ever been able to find of a sacroiliac joint. It shows a little space there. Okay? Now, each sacroiliac is different from side to side. At the Philadelphia school, when Angus Cathy was the head of the department, he had a big bookcase with a glass door on it. He had 100 human sacrums in it. They were all different. See, and we assume with their techniques, the sacrum's always the same. Okay? How's that going to change your technique? So they're different from side to side, and they're different in every person. Now, also, when you look at the cartilage, there's a fine texture to the cartilage, almost like sandpaper. You think, why is that? And it's so when that joint moves, it never goes through the same pattern. It fractally goes through a little different pattern each time, and it doesn't wear a groove in that. So it's a protective system. Isn't that pretty neat? And then, why do we have all those posterior ligaments? To support that sacrum. So then I came across an article called Floating Compression. It's another tensegrity system, and that slide will be up in a minute. And that description is unbelievable. Now, in Europe, do you guys teach form and force closure of the pelvic gait mechanics? They do in Europe, and I just have trouble with it. The guy that's done it is Fleming, and I've had more arguments with Fleming about this. Is when I watch people walk, I just have trouble that it's locking up. But tensegrity would allow you to have nice movement in there, and I think that's more what's going on. So I think if there are grooves, big grooves to protect it, I think that's a backup system. And I think if we started treating people as infants and treat them whenever they came into primary care, obviously, is there any low back stuff going on? Let me check it. I think that tensegrity floating compression thing would work a lot longer in their lives. And the floating and closed pack may be a backup system. Because the grooves that they say occur, the closed pack people say, there are grooves in there that support that thing. Willard says they don't occur until our 20s and 30s. Well, when are we the most active? It's teens. Wouldn't it make sense you'd need them then? See, so I think we need about 10 secretaries working then. Now, look at this definition of floating compression. Describes a closed structural system composed of a set of 3 or more elongated compression struts within a network of tissue tensions, tension tissues. The combined parts are mutually supportive in such a way that the struts do not touch each other, but press outward against nodal points in the tension network to form a firm, triangulated, pre-stressed tension compression unit. And when I read that first term, I thought, somebody just described what I feel like I'm palpating when I'm doing functional in the pelvis. And that describes it. And here's another, these are attractors that represent complex data. And they never explain what it's due to, but it's a picture of a lot of complex data. My fantasy is this is a lot of complex data, and great, here are the 2 innominates, here's the sacrum with the 3 transverse axes. Whether that's true or not, I don't know. But here's just one piece, here's one before. This is called a butterfly. And it's heel strike on the left, toe off on the left, heel strike on the right, toe off on the right. And what you want is symmetry, and you want healthy variation. It's almost like musculoskeletal heart rate variability. And you want some healthy variability in there, right? But you don't want a bunch of chaotic stuff. And then if you take that same data and like stand the patient up, this is the center of pressure. So look at, there's a lot of craziness here in the center of pressure and then at toe off on the left. Treated the patient, put him back on the treadmill, and look at this immediate change. Isn't that pretty neat? We've got hundreds of these. We've done old people, young people, fat people, skinny people, average weight people, pre-total hip, post-total hip, pre-total knee, post-total knee, arthritic car accidents, shoulder problems. We've done it all. And what we're trying to find, is it consistent? And in 80% of the patients I treat the first time, we see dramatic changes like this. So, the landmarks, some people are teaching landmarks a little differently. The way Mitchell did it was he said, find the posterior superior spine, go medial, then go a little anterior, because you want to be on the most superior part of that sacrum. A lot of people say this is the ILA. It isn't. The way he taught us to do it was palpate the spines of the scapula, the sacrum, find the sacral hiatus, go a little lateral inferior, and where he described the ILA is at the junction of the coccyx and the sacrum, just lateral to it. And if your reference point is, is here ILA and palpating here the sacral base here, a lot of times your findings won't be consistent with the Mitchell model. So look out, make sure you're palpating in the right spot. Now, here's where I want to stress, and then we'll do some practical stuff. Mitchell said sacrums, they can be shaped like this, or like this. Okay? Then also, when you look at the articular surface here, sometimes it's in this plane, sometimes it's in this plane, sometimes it's in this plane. Okay? So you can have a lot of variety in what you're palpating. Okay? So if you do it by textbook and be competent with what the book says, lots of times you don't get a good outcome because you haven't addressed these issues. Okay? So, let's, now I rechecked Greenman's book, and Greenman was a dear friend. I love the guy, and the last time I talked to him, before he died, he said, you know what I think was my greatest accomplishment in my whole professional career? And I said, what? He said, when Viola Fryman asked me to treat her with high velocity. Like that was, she had some respect for it. Now, what, if you read Greenman's book, he says you abduct the leg 15 degrees, and then you internally rotate the thigh, and see, it's good thinking to open up the sacroiliac joint. But wonder if that sacroiliac joint's in this plane. Wonder if it's could it lock it up? Okay, and wonder if the sacrum is more in this plane. Are you going to have to abduct that leg way past 15 degrees? Okay, so I need a patient